Well, hello there, and welcome to this podcast. A little different. I do this weekly podcast called No Neutral Moments, and the other day I was scheduled to do a Facebook Live with our guest here today, Dr. Larry Wilson of Midland Health, or Midland Memorial Hospital. And the more we got to thinking about doing this Facebook Live, I was sitting there thinking, wait a minute. We're going to be sitting right next to each other in my living room. That probably won't go well. And then we're going to be in face masks. That won't sound very good. So we just got to thinking, well, why don't we just record a podcast? People can download it from my social media, and the hospital might want to post it. We'll see. And just have a conversation about COVID-19, the coronavirus, where we've come from, where we're headed. And although you're not able to ask us questions, I imagine we'll probably address most of the questions that you might have. So with that being said, let me introduce our guest. And Dr. Larry Wilson, welcome. And why don't you just tell, what's the right word, the listening audience, a little bit about yourself, your background, your education, how you got here to Midland, and all that, and then we'll dive into other stuff.
Sure. Thanks very much for having me with you, Mayor. My name is Larry Wilson. As Mayor Payton mentioned, I'm an emergency medicine trained physician. I started my career with the Army, born and raised on the West Coast, Pacific Northwest area. I've been in medicine for 30 plus years now, trained with the military and was in the military for about 14 years. When I finished my career with the Army as an emergency medicine physician, I came to Midland. Really had, because of my military career, I had spent a little bit of time in Texas and liked it as a family-oriented, focused place with a young family at the time. And my wife and I thought getting back would be good. And because of my medical military career, I had been in San Antonio, had never visited Midland, Texas before. And I had a goal of getting to San Antonio perhaps, or one of the bigger cities, and started looking from the West Coast where I was in the military at the time, and found my way to Midland, Texas by a sort of circuitous route, thinking that it would be a good stepping stone, get my feet planted, become a resident of Texas, and then kind of move to another location. And I grew roots here. It was good for my family. It was good for me. The hospital here has been very good and a great opportunity to progress in emergency medicine. I was one of the co-owners of the emergency medicine group here for a number of years, and found that as I got later in my career that just practicing as an emergency medicine physician, although very fulfilling, and I've loved my work every day, I think you're very lucky if you have a career, any career, that you enjoy going to every day, because you never have to work a day in your life. And I feel truly blessed that way throughout my emergency medicine. But I saw opportunities to be more of a public servant, more of a help in terms of progressing medicine on a larger scale than one patient at a time. Went back to school, got an MBA, worked through medical staff leadership roles, and found myself in the job of a chief medical officer of our hospital and the vice president of medical affairs for the hospital, working with the physician and liaisoning physicians with the hospital goals. As you know, the hospital sees itself as in the role of not just being a hospital for our county, but as a role of being the healthcare center for our greater Midland area, looking to drive healthcare for the greater Midland area with a vision of creating the healthiest community in the state of Texas. And I really like that mission and vision that Russell Myers and the board have put forward, and I'm very proud to be part of that team.
So in the military background that you had, where did it take you in travels? I mean, was it mostly here on the state side, or were we able to go in the military?
I was stationed in Hawaii for 3 years, and that was the only time out of CONUS, or out of the continental United States, that I spent. But I had a couple of brief training operations, never deployed to the desert. The Desert Storm was going on when I was in the military, and we had two other members of my group at Triple Army Medical Center in Hawaii that were part of rapid deployment forces. I was assigned as a medical leader of a rapid deployment task force for the Trust Islands in the South Pacific. So I did some training operations out in a variety of different places out in the South Pacific, and got a lucky opportunity to spend some time in Fort Polk, Louisiana, doing some field operations there as well, but all training. So never deployed overseas, never had an assignment overseas, but East Coast, West Coast, and Hawaii were my career.
How long have you been here?
I've been here for going on 24 years now.
24 years. Yeah. So you got here about 96 or 97?
97.
Because I got here in 99. So,
okay.
You said you've never had a day of work in your life because you have enjoyed your career. How does this particular season stack up to anything else you've encountered?
Yeah, so, 6 months ago, COVID was a word that we heard about a new virus that was dripping out of the wet animal, farms in China, with little concern that it was going to find its way to us. And over the course of just a couple of months, we found that it spread worldwide, and it's been something that I have never experienced in healthcare in my life. I've read about the 1918 influenza event that spread over really about 18 months or longer, that people were getting sick in different seasons. And I think this is probably the closest thing we've ever experienced to something like that. But, it was, for us, I think here in West Texas, it came right on the heels of the oil, crash, so to speak, or the drop in the oil prices and layoffs and other issues. So it's just been a real double whammy, I think, for everyone. And it's, I think 2020 is shaping up to be a year I think we would all like to forget.
Yeah, I think you're right. So let's dive into the coronavirus, COVID-19, and for simplicity's sake, describe what it is. We've all been bombarded with media and information for the last 6 months. Just describe what it is. We mentioned a minute ago, I've heard people say this disease. So talk about disease, virus, and just clarify for everybody what it is we're dealing with. It may seem like a simple question, but it might be an important one.
Sure. So there's, coronavirus has been with us for quite a long time. We have a rapid test that we can do on anybody that comes into the hospital with respiratory tract illness looking for flu or RSV, which are common ones that parents know with their children and with adults with influenza. But it has a panel of about 20 other viruses that commonly cause colds or seasonal illness. And there's 4 coronaviruses that are on that list. The difference is that a number of years ago, we had the initial SARS virus. That's another coronavirus that mutated and normally found in only animals. It found its way into human beings and caused a pretty severe acute respiratory distress syndrome. So it's SARS. But that was a coronavirus as well. And then MERS, which came out a couple of years after that, again found its way into human beings and again was a respiratory tract illness found initially in the Middle East. And again, is a coronavirus. And then here we are again in 2019, really 2020 mainly, but it started in 2019, so it's called the COVID-19 virus. It's a coronavirus that's found its way into human beings and causes a severe acute respiratory distress syndrome as well. Differently than the others, this one unfortunately has proven to be more transmissible and longer-legged than the others. The other ones kind of died out after a period of time for reasons that I'm not sure if everybody understands, because they have cropped up, every year, 1 or 2 cases, but you don't see much of it, you don't hear much of it. But this one's really been hanging in there. It's very transmissible from person to person, and the vast majority of people that get it don't get terribly sick, which is very, very fortunate. There's been recent information suggesting that younger kids don't really transmit it very well. Older kids and adults transmit it pretty easily. We were hoping a wet or hot, dry climate would help diminish it, but unfortunately people close enough together it can carry long enough in the air before it dries out. But it is a wet water droplet transmitted virus that will tend to die quickly in a dry area. So if we stay far enough apart and we let the air dry out between us, it's very likely we can let the virus die in that setting. But unfortunately, although 50 or more % of the people that get the virus won't get terribly sick, well, I mentioned to you before we came online, my son had it. He's 32 years old. He lost his taste, had a couple of days of a headache and some myalgias, some body aches, and then largely recuperated at home fine, other than complaining that he couldn't taste food, for about 2 weeks. And then that gradually went away as well. And I've heard a lot of stories like that and even simpler, with even milder symptoms. But we at the hospital are very acutely aware that 20% or so of the people that get it can get pretty sick. And some of those people are lucky enough to recover at home. Many aren't. They require oxygen or other interventions to help them be well. And then of that 20%, a subset end up in the requiring ventilatory support on ventilators and in the acute critical care unit, and some of those people die. About 45% of the people that end up in the critical care unit in our hospital are passing away, which is a little better than the average around the nation, but it's still not good.
Yeah.
And so that's the virus as we know it. It's still called the novel coronavirus, and it's called novel because it's new and we're learning new things about it every day. I think, we talked a little bit about this before, that it's so frustrating to everyone and to us in healthcare as well, that, the news of yesterday that seemed very promising today has proven to not be likely to be true. And there's a lot of misinformation that fills in the gaps. When people don't have information and they want information, they tend to make stuff up to fill it in. It's human nature, I think. And we have to be very careful about that and try to stay on task with what we do know and stay nimble so that we can change as quickly as the virus is becoming known to us.
So I know you've heard this comment. I promise you, no gotcha questions in this whole thing. But I know you've heard people say, well, this is just another flu. Mm-hmm. So address that and what's different? What is the same? Are we expecting that's kind of what this will be someday? Is it mutating? That's a lot of questions. So just take off from there.
Sure.
How you want to go in that regard?
Sure. So I hope people in the general public are beginning to recognize, but certainly we in healthcare recognize, this is not the flu. The way that this behaves and the people that we get in the hospital, it's very, very different. And let me enumerate a few of the things about that I think are relevant. One, influenza is a number of different viruses that tend to start off in other parts of the world, oftentimes in Asia, other places in the world. And every season, every year, it mutates a little bit, so that we're constantly battling to try to put together enough in the vaccine with different antigens that we can cover the flu of any given season. And many times we're right, many times we're wrong. It's non-discriminatory in terms of age, and as such, when viruses or any infections that affect people, when they will influence any age group, the people that tend to do worse with it are those at the extremes of age. So very, very young children, it can be lethal and dangerous for them, and for very, very old people, it can be lethal and dangerous for them. And anybody with underlying comorbidities and illnesses, diabetes or what have you, can tend to, or especially the respiratory tract infections, can tend to have a tougher time with respiratory tract infections as well. The coronavirus, different than that, seems to be a little bit more selective in the people. As I mentioned a little bit ago, it doesn't seem to be really bad in young kids. Tends to be as you become a teenager, an adolescent, young adult, and older. It tends to be a little bit selective in age and people that will infect. A lot of the people, influenza, you don't get it and not know it. With coronavirus, half of the people or more can get it and not know it, or have very, very minimal symptoms, but then be out there and transmitting it to others because they don't know they've got it. So it seems to be more transmissible than influenza, seems to be getting wider spread. And then, unfortunately, a subset of the population that, like an influenza, would not be considered as dangerous, this will kill or will make them very, very sick. As I mentioned, 5 to 10% of the people will end up in critical care, and half of those will die. 20% of the people will end up visiting the hospital or staying in the hospital. And influenza is not that hard hitting in those respects. So at the end of the day, if we do a really good job and we protect people well and we get through the next several months and get to a point where we have a vaccine or a better treatment, we may find that the ultimate mortality rate may be much lower than what we've seen. But the usual mortality rate of influenza is like 0.16% or 0.2% or less than 1%. I think that the 1918 pandemic of influenza was a little over 1% lethality. What we're seeing with this is several percent, 2 to 3% mortality rate. Of course, some people are arguing this because we're not testing widely enough, and if we had a bigger number in the denominator, it would be a lower number. But I'm not sure that's true. I think that this, at least what we're seeing in the hospital, people can be sick for a week, 10 days, 14 days, and suddenly just get much, much sicker. So it seems, again, it's novel, so we have a lot to learn, but it seems more dangerous, more transmissible, harder hitting than influenza.
What is what does turning the corner look like on any of this? I think that's the question I keep hearing is,
Yeah.
so what are we looking for?
Right.
What's changing for us?
Yeah, the key, I think you've heard the people talk about herd immunity. Getting to a point where enough people have antibodies to the infection that if it starts spreading amongst a group of people, it dies because people that are in that group have previously been exposed to it and they don't carry it. You need at least 60% of the population to be infected. I think if you look at the numbers that we have in Midland, we're less than 2% of the population, so we have a long way to go, and we're 6 months into this. So there's some form of herd immunity, and the goal, I think, realistically, is to keep the burn low enough, long enough, that we get to the point that we have a vaccine that will work. Last I heard, viable, well-reputed companies, maybe 20 of them are in the mix right now with vaccines. Other upstarts are out there and may come up with something as well. But there's at least 20 out there, and there's probably 3 or 4 that are in stage 3 trials now, meaning that they've done trials with humans. They've done dosing in humans. They've shown that it's not deadly. Number one, that the vaccine is that it actually helps people or keeps people from getting sick. And that's the early data. That's all they're really looking for. But in that, they've also seen antibody production, which suggests immunity. So now they are ready for larger scale studies. And I believe like Moderna, for instance, is one of the big companies. And they're ready to launch a 30,000 patient test. And then they'll not only give them the vaccine, make sure that they survive the vaccine, but then make sure that they, when exposed to the COVID infection, that they do well and don't get it.
Can I have the coronavirus, never show a symptom, not get tested, be past it, and be immune?
Yes, we believe that's true. I don't know if that's been absolutely proven, because it appears that the antibody production, which is the immunity factor that we produce, seems to be higher titers of antibodies in people that get sicker. So milder symptoms tend to produce lower numbers. And there's actually been some studies that have looked at populations of people that were diagnosed with COVID-19, and they've done subsequent antibodies 30 days later, and a subset of that population, as high as 50%, had no detectable antibodies.
Yeah.
So that gets a little questionable about where you are in that. But having said that, I have spoken to people that have had either minimal or no symptoms and had tested for antibodies and had antibodies.
Okay.
So I'm pretty confident that some people definitely do, but there's a scale, and exactly how that all plays out is yet to be learned.
How smart is this virus?
Well, I mean, it's a virus, so it's not intelligent in the context that you and I think of intelligence, but it's wily. I think you've heard me say that before. I mean, it seems to be able to find its way into people and not make them sick, and allow them to spread it to a larger population of people before, and then some of the sicker people or people that get sicker end up getting it. More vulnerable people. I think what you're driving at there is that is it quick to learn and adapt and change. And so far, the information seems to suggest that that's probably not true. It doesn't mutate as rapidly as influenza, for instance. So that changing surfaces on the virus, enabling it to still enter our cells, but to avoid antibodies that have been previously produced to it, is the concern. So that year over year, you'll have to have a new vaccine. And that's not known yet, but there's some optimism that it's not mutating as quickly as some other viruses. And so we might have some luck in having vaccines that can produce longer-term immunity than just one season.
When we started back in March, and you're right, it was right on the hills, everything came together all in the same time. I remember that it was the energy crisis, the 1st of March, and then probably a week later we're all having press conferences. Talk about testing. I remember when we started, it was you're not going to get a test unless you're showing a series of symptoms. And then there was an outcry for production of tests, and then how many people can we get tested? What are the pros and cons we've been seeing with testing? Is it all good because we're testing? What are the numbers associated with the efficacy of a test? What are you seeing as a physician that might cause you pause related to testing? Because I remember when we did press conferences together, we get a lot of testing questions, and you could tell they were a lot really fear-based. We understand that. We totally get that. Now there's, and I'm not talking about just Midland, the country. There's more and more drive-through tests. There's more and more of this. What's changed that we're saying get tested whether you're symptomatic or not? Just the whole testing world. Help our listeners kind of get out of CNN and Fox and help them get into the mind of a physician related to the whole testing piece.
Okay. So, I mean, it has been a moving target for a lot of different reasons. And I'm going to give just a real brief global overview of what we do with testing. So you've heard a lot about PCR testing, which is an RNA-based test. And then there's the antigen test, and then there's antibody testing. So those are three things I'll just touch on really briefly. The PCR testing is, without question, is the most sensitive and specific testing that we can do. We can capture RNA that's in somebody's respiratory tract, particularly because mostly it's a swab-based test that goes into the nose or into the nasopharynx. And if there's any RNA that comes from the virus in that person, it'll be detected, and then the polymerase chain reaction will actually amplify what you find to enough of a amount of it there in the process that then you can find it and show yes positive for the RNA. The problem with that is that people that have recovered from the virus and no longer are carrying active virus that can be transmitted me to you or you to me may still have remnants of RNA in their respiratory tract for weeks after they've recovered. So to test for recovery, if you use that RNA-based, the PCR testing, you may find RNA when a person is feeling perfectly fine and cannot transmit the virus to another individual. So they've actually recovered, but they've got what we call cadaver RNA or dead RNA remnants still in their system.
So let me stop you right there. So when I'm talking and I'm listening to companies who have an employee who started becoming symptomatic, went and tested, a lot of them have some young employees. They stay home, they quarantine, they go back after a 14-day quarantine. They felt fine, but the test shows up, you're still positive. That's what you're talking about.
Exactly. So it makes it difficult for employers to put people back to work.
Right.
So that's a challenge, and it's not accurate information in that context. So for testing for disease, if somebody has symptoms or you're worried about having a significant exposure and you're going to be traveling somewhere where you're going to be around vulnerable people, your best test is a PCR RNA-based test. If you're testing for cure, it's not the test that you want to go for because it can show that you have RNA, but you may not have the virus. So then that leads us to the antigen test. So the antigen test is a test that looks for surface markers on the viral shell that may be in your system and detects those. So it's detecting proteins that are on the shell of the virus. And that test is not as sensitive as the PCR test. So up to the one that we use at our hospital and that a lot of people are using around town now is called a Quidel Sophia 2 test. And that test will miss out of 100 about 15 or so positive people. So you've got the virus, you are infected, we test you for it, it comes up negative in about 15% of the time. Now, if you test positive, it's just as accurate as the PCR test. So if you have the virus and it tests positive, if you test and you have a positive test, you've definitely got the virus. If you test it as negative, there's a reasonable chance that you really still do have the virus. Mm-hmm. So for people that are at high risk, you want to do the PCR test to make sure you're captured if you can. If you have to do the antigen test, I would do it multiple times because then you narrow that gap. That 15% reduces time and time again. And I don't remember the math of this, the probability theory stuff very well. But my Dr. Klingensmith, one of our pathologists, says if you do the antigen test 2 times, you're up to 95% sensitivity, so only 5% miss. So, and if you do it one more time, you get higher than that. So there's an opportunity there for getting it narrower and narrower. So the antigen test is more readily available and more widely available. But if you are concerned that you have the infection, I would not rely on it for proving you don't.
Okay. What would you rely on for proving you don't?
The PCR test.
The PCR test.
Yeah.
Okay.
And unfortunately, there's not a ton of that available at our hospital where our supplies are getting lower and they're not being resupplied with regularity. So it largely is becoming a send-out test. So when you go to some place like a lot of the outpatient clinics, you're getting an antigen test 9 times out of 10. And that antigen test, if you think you really have the virus, is not going to be a reliable test to prove you don't.
Should a person, well, in our city, are people getting tested asymptomatically because they just want to get tested?
Some, yeah.
Okay. Should people still wait to be tested? Should they still give it I need to have a fever, I need to have a persistent dry cough, other symptoms? Should they wait? Or the minute they think they feel bad, should they go get tested?
Yeah, so I think a good answer to that is if you're feeling symptoms at the earliest onset of symptoms, I would get tested, because it seems that the viral shedding is highest 1 or 2 days before the onset of illness, and for the next 3 or 4 days after the onset of illness, and then the viral shedding seems to diminish by and large. Doesn't mean it eliminates it, but it's a lower, and that's why the CDC, I think, new guidelines are kind of narrowing the window a little bit for that, because it's recognized that your infectivity decreases pretty quickly around that. So if you feel like you've got symptoms, but if you're having no symptoms and you think you've been exposed and you just want to get tested, by and large, an asymptomatic person, likelihood of finding virus is really, really remote.
Okay. What concerns you the most? Well, okay, let me back up. How are we doing on treatments? We hear something all the time in the news. I hardly know what to believe anymore. What, in your opinion, has shown to be the most effective? And if you want, address issues that we keep hearing, and I don't want to get political or throw anybody under a bus or anything, but we found this, we found that. It seems like there's a lot of searching going on. Yeah. But in your experience and in your research, what are you finding has been most helpful? And it seems to be mostly those who have been in the hospital, because if you test positive and you go home, if I've heard you correctly, most of the time the treatment is pretty generic. I mean, it's take Tylenol, it's rest until the symptoms are gone. So your son was probably, sorry you can't taste anything, but here's your Tylenol, stay in your place, and we're not going to come see you. So talk about treatments.
Sure. So let me start that by saying I would encourage anybody that hears something, especially when it sounds like way better than anything else you've been hearing, to do your own homework, do a little research, go online, read about it, find out for yourself, trust your own intelligence and your own ability to find it. This stuff's available on the internet. Some of the articles are geared towards medical trained people, so they may be hard to follow, but they usually have an abstract at the beginning with a conclusion that can give you some pretty straightforward language that is usually reasonably correct. Make sure it's peer-reviewed information that comes from a reliable journal like the New England Journal of Medicine or JAMA, Journal of the American Medical Association, or other sources. If it's something that you haven't heard before, don't trust it necessarily. Do a little homework around where it's coming from. So I just start with that. And then what we've learned and what we haven't learned with this. So, this has been a moving target from the beginning, and I'm going to go back to hydroxychloroquine, azithromycin, zinc, all these therapies that people are throwing around. And they've largely been shown not to be nearly as effective, if effective at all, through bigger, larger, more reliable studies, which are basically studies that you take patients and enroll them in it without and don't bias the individuals that are treating them so that they're blinded to what you're doing, and you either give them a sugar pill or you give them the drug, and you see how people do. And if it's if you get into that a few dozen people and you're seeing this remarkable benefit, you don't have to keep doing it. You can start saying, "Oh, this looks pretty effective," but by and large, we haven't seen anything like that. There's been nothing that's been tested that's just shown remarkable efficacy that we just say, "Oh my gosh, this is the drug. Let's just start doing this," because that would spread like wildfire.
Mm-hmm.
We all want a cure. We all want something that will work. The minute we hear something that's really making sense and it sounds too good to be true, we'll try it if there's no harm to be had with that. So everybody wants that. We all want people to get better. There's no benefit to us. We lose money every time a patient's hospitalized with COVID. I'm sorry to say, but it's true. But we don't. It's our mission. It's our job. But it's not a money-making proposition. We'd much rather be doing surgeries and endoscopies and elective procedures, et cetera, to keep the lights on and the doors open. But that's not the way that it's played out. So with hydroxychloroquine, let's start there because that's a largely talked about and it's been in a lot of people's minds. It has been shown to be, if anything, harmful on hospitalized patients, in larger studies that have looked at it. So it's not beneficial in that population, largely probably because those are sicker people. They're going to have underlying other cardiovascular other problems, and those are the people that can potentially be harmed. A lot of outpatients are treated with hydroxychloroquine for malaria and for autoimmune disorders. They have been for a long time. It's very, very safe in that population. And there is some evidence that it may help in either prophylactically in helping prevent getting the infection, or that it may help diminish the degree of infection. It's weak, but it's at least likely not harmful in that population. So I'll leave it to doctors to decide if they want to use it for, I'll tell you, I love my son very much. I didn't put him on hydroxychloroquine, so I'll put it that way.
Yeah.
But or I didn't advise he get hydroxychloroquine. I wouldn't treat him myself anyway, but I didn't push him in that direction. So hydroxychloroquine, I think the jury's still out in some respects, but largely not beneficial to anybody we're going to have that's sick enough that really needs something. And by and large, if you're outpatient, you don't really need anything anyway. You're going to largely get better, all by yourself. Almost everybody does pretty much, unless you're going to end up in that 20% that we talked about. Drugs that have shown some promise that we've seen is the remdesivir that you've heard about. It's probably not as beneficial as people had thought or hoped for sicker people. So people that show up already going on a ventilator, for instance, and requiring high oxygen concentrations. It seems to be not very beneficial in that population. But people that do come in that do have an oxygen requirement at a low level that are hospitalized and you watch them for a day or two and you see that they're not turning the corner, that if anything they might be getting more sick, that population can benefit from remdesivir, it appears. So initial promising for anybody who's got the COVID infection that's hospitalized. Now it's got a narrower window of people that it's beneficial for. But it is definitely beneficial in that population. We like getting it. It's a limited supply drug right now. The state and the government oversees how it's allocated to different regions. We get an allocation in our hospital. I'm sure in MCH in Odessa and ORMC also gets some. And I don't know what their intervals are, but we get it every other week. We get about 60 vials, and that's enough for treating 8 to 10 people potentially, or maybe a few more than that, depending on how many vials they need. So it's not a completely available drug, but it does have benefit when we use it. It also appears that steroids like dexamethasone IV or orally in people that are getting more sick, so kind of through the COVID infection but now have the post-inflammatory process going on, can benefit from those. So the studies seem to suggest that if you're on a ventilator or you're requiring high oxygen concentration for your therapy, steroids like dexamethasone, IV or orally, are beneficial. It seems to be the case. There's some newer drugs that are out there. I had an article forwarded to me from Dr. Gary Venolini, who's with Texas Tech, about antibodies, monoclonal antibodies that are basically laboratory-made antibodies driven towards specific protein markers on the virus that are showing remarkable promise. So you've heard us talk about CCP, and I'll touch on that again here in a minute, but the COVID convalescent plasma. So somebody who's recovered from the infection, as you were talking about earlier, that has antibodies in their system, we can take their serum that has those antibodies, give it to another person, and in many cases they'll benefit from it. We've recognized that in some people you give it a serum dose, doesn't benefit them. You give them a serum dose from another donor, and it does benefit them. So we're mixing that up, and finding the right people that have the right antibodies and that we can benefit people with. Monoclonal antibodies is basically artificially generating antibodies that can be beneficial, and if they can mass produce those, that can be a real sort of strategy changer, a game changer for the whole process.
Synthetic antibody, basically.
Essentially, yeah.
Okay.
Yeah. And then convalescent plasma I just mentioned. Unfortunately, like the remdesivir, the more you need to use it, the harder it is to find because there's increased demand in all the hotspots around the country. They're all demanding it. So we've ran into some situations where we're requesting it and it takes 24 hours to get it, but we are getting it. But we're hoping to get it more rapidly. So I think one of the take-home messages from all of that is that as they develop new strategies and we find new drugs, They're going to be in limited supply for a while. And the lower the burn we keep on this, the more likely we'll have enough medications, enough treatments, enough testing for the number of people that we have until we get to that game changer, that vaccine or that monoclonal antibody or some other therapy that's really remarkably effective. But today we have nothing like that. What we do have, the most effective thing we have with all of the drugs I just mentioned and all the opportunities that are out there, the most effective thing is prevention. And it's been shown time and time again. And I know, the beginning of all this, I was one of the people saying there's no benefit to wearing a mask. I remember having conversations with people in the hospital about there's no benefit to wearing a mask when you're not around the COVID patient. If you're around the COVID patient, you want the N95 mask to prevent exposure, et cetera. That went on for about 3 or 4 weeks. And then it became increasingly apparent that mitigating your breath getting out into space can decrease the likelihood of others being infected. It's all about how close we are when we're breathing, so water droplets can transmit. If you and I are this far, Mayor Payton and myself are sitting more than 6 feet apart, and I think we recognize that there's a benefit to doing that. If we were sitting shoulder to shoulder and one of us had it, there's a chance that the other one's going to get it, especially for the length of time that we're in here and how much talking I'm doing, especially if I had it, it would be out there. But if we keep our distance from one another, and when that's not predictably possible, if we can't maintain a distance, we wear a face covering to decrease the amount of our water droplets getting out into space. It's been demonstrable that we can decrease the infection. In every place that they do it, that's how you reduce it. There's been some people talking about using some oral inhaled steroids and other things that they say have been so remarkable, and they've said that they've been beneficial when you see what's gone on in Taiwan or you see what's gone on in Iceland and these other places. Well, I did the homework around that. I went and looked at what Taiwan did, Korea did, what Iceland did, and it was social distancing, public health processes, face coverings, and that's what's in the literature about what they did that was effective. It had nothing to do with any therapy. It was keeping people from getting sick. If you look at Taiwan, for instance, and I did the math on this, their total number sick, they had only had 7 people die in the whole country. But their total number sick was low enough that when you look at the mortality rate, it was no different than we have here in Midland, Texas. So just as many people die from the virus, just not people didn't get the virus. Mm-hmm. And they kept people from getting the virus by wearing the face coverings and maintaining social distancing. And I truly believe we can get kids back to school, we can get economy going and do everything else we need to do by adapting to a new normal in terms of the way we behave. And we can get out and have lives, but we just do it apart more than we've ever done it before. It's a different world, and it'll be that way until we have some form of either a cure or a treatment that will beat this disease down.
A cure, a treatment, is there a third option of it becomes very similar to the way we live with the flu? And I'm not trying to make it a flu.
Yeah.
But, because somebody could be listening to this and say, Dr. Wilson just said, our new normal is from here on out, we're going to wear masks unless everybody takes a vaccine. But is there an option of, how long do you do this? Does Taiwan not have the virus anymore? No, they still do. And do our listeners, are they just going to have to settle into, this might be the rest of your life that we live this way, or is the third option, we're at 2% now, but at some point it becomes like SARS or whatever it is that we say now, because there's a vaccine out there that, sometimes I think in 2018 in Texas it was like 40% effective, but it's still, we just know it's here. This is how we live.
Right. Yeah, so I'd like to remain optimistic. There's a couple of things to that. One is that I think I've learned, and I think a lot of other people have learned too, and I remember, traveling through airports in the flu season in different areas, and certain individuals, particularly Asians, were careful about face covering. They would have a mask on while they're traveling around, and I used to kind of scoff at that behavior. I think I'll be more that way myself. When I'm traveling in environments where there's a lot of cloistered people and it's in the season where there's a lot of respiratory tract stuff going on, I'll probably wear a face covering going forward. I've learned from this that it makes a difference, and we can reduce the disease spread. So I think we all can be a little bit more aware that there is benefit to maintaining social distancing, watching out for that stuff, face covering. But I do believe also that we are a resilient animal, human beings, and we will overcome the coronavirus one way or another. And I believe that there's some evidence, and there's people that speculate also that the longer it's around us, the better adapted we will be to it, and so it will become less virulent in the sense of being so hard hitting. Especially somebody may have gotten a low dose of it into their system, maybe didn't get sick from it, but maybe produced a little bit of an immune response. So if they get exposed to it a second time, they're not going to get as sick. As the vaccine comes out, we'll be a little bit better off that way too. But I do think that it'll kind of settle into being something that we'll see year over year, but we won't see it nearly as dramatically. I mean, the influenza at 18, it died away and went away. And the same virus is still out there, and every so often people get it, but it doesn't create the pandemic that it did. And the same thing's going to happen with coronavirus and with the next virus that comes along.
The next one, yes. Yeah. What are, you already mentioned it, but in your professional opinion and knowledge, it just seems like this season of face coverings, which in West Texas might be harder to get people to do than it is for them to cheer for a particular sports team. I don't know what the analogy is, but it's really because we just don't know. And I've told people about the only thing I can control is what I'm doing with my own health and the health of people around me. And I think that it's still true to say, for instance, when I'm around my in-laws who are up in their age and have a pre-existing condition of a heart condition, it's fair to say we need to take care of what we're doing around them. And I can't control what's going on at the grocery store and so on and so forth. There's other extremes, though, where I get multiple emails where people still want to tell me they saw a couple out walking outside, taking a walk. And I'm like, well, let's be careful about assumptions we're making about what people are doing outside. But it seems to be that for now, for this season, and we can't project when this season ends, this preventative piece of put a mask on when you're out in public, when you go keep one in your car, keep one in your briefcase, and keep one in your office, and just be aware. Yeah,
I think you said that perfectly. We've learned a lot. I remember the early days with the Unified Command, and we all were not convinced. I was not convinced that face covering was going to help. I did believe in the social distancing piece early on, and the hand washing, et cetera. It seems that this is mainly aerosolized. It's much more likely that I'm going to get it, or you're going to get it from breathing, close to somebody else than you are from touching a surface. And so I think there's that's the bigger issue. But I think you said it perfectly. I mean, we have to be sensible about what we do. I like to go outdoors. I know you're a runner too. I like to go outdoors and run. I'm not going to wear a face covering when I'm out running if I can maintain 12. I see somebody walking in the opposite direction. I go to the opposite side of the street. Because I'm breathing pretty hard when I'm running, and I don't want to expose them to my breath, and they may be doing the same thing. So it's just better to keep a wider berth. But there's a lot of circumstances, and we can all think about what they are, where you cannot predictably avoid close contact with people. If you're going to a shopping mall, or you're going to a store, or you're going to a business, you're going to walk in a hallway, you're going to walk down an aisle or something like that, and you're going to be in close proximity to other individuals. In those kind of settings, wearing a face covering is respectful of others' health, and it's respectful of them showing respect for your health. You don't know if that individual might have diabetes, hypertension, or what have you, and you may not care if you get the virus, but it may be life-threatening if they do. And we just have to be thoughtful about that. And it's just, like you said, I mean, it's not fun. I don't like having to remember to bring. I drove to work one day, went into my glove box and didn't have a mask, and I had to go home and get one. It's really frustrating, but it is the reality of the world right now, and will be for the foreseeable future until we get to a better place with this. Yeah.
What final thoughts? Just, one shot. We may have thousands of people listening to this. You're kind of closing. This is what I want you to hear from the medical community about what we're going through.
Sure. I think everybody has seen what happened when we started off and we didn't know what we were dealing with, and everybody had a level of concern, and we went to the complete shelter in place, stay home. We all bought into that. Clearly, that had benefit in terms of decreasing spread of this virus amongst our communities all over the country, but it also had demonstrable ill effects in terms of the economy, in terms of people's well-being, a lot of factors in people's lives. So somewhere in all of that, there's a balance. And that's where we've got to find ourselves. We have to be thoughtful about the way we approach it. We have to be careful, learn from what we can learn, trust people that have good information, look it up yourself, learn as much as you can about what is true and what is not true. I'll tell you, the social media is full of misinformation. I'm sorry, but it truly is.
It sure is.
And just be careful. You hear something, and if it sounds too good to be true, it probably is. But, we've learned from that. But I also fully recognize that things I'm saying today, I wasn't saying 2 months ago. And if you look at me as being an expert, then, what do you trust? You look at Dr. Fauci and others, they've changed their opinions in some respects too. But trust that we are constantly looking at the latest information and developing with the acumen of knowledge from years in medical study and colleagues. We're pulling out the best information we have and doing the best we can. We're only 6 months into this. We've learned a bunch. We also still have a lot of gaps in what we know, but we need to stay the course. And we know that the best way to prevent this thing from burning out of control is prevention, and that's social distancing, face covering. We got away from that for a while after we got away from our shelter in place, all the way up until around the 4th of July. We're suffering the consequences of that today. Our hospital has 14 patients in the critical care unit and 35 patients on the medical floor. We've had multiple mortalities in the recent weeks. I'm sure you've seen that in the paper. That's all related to indiscretion in terms of our behavior 3 weeks ago. The behavior that everybody seems to have adapted since Governor Abbott and fortunately our mayor also got on board and said, please let's be careful about this. We've all seemed to have stepped it up a notch in the last couple of 2-3 weeks, and we'll see the benefit of that in the next 2 to 3 weeks. And if we keep it at a slow burn, we can get back to life. And we can get back to doing things that we need to do to get the economy going, but just do it with the new normal until we get to a point that we're in a better place.
Would you say, and as we're closing thoughts, we could even get back to a more open economy if we were even more diligent and disciplined about these things we don't want to do?
Absolutely. I truly believe that.
And I know listeners sometimes will say, well, we're not Asia, we're not China, we're not Taiwan. But the reality is, as you mentioned about your airport example, I've traveled internationally quite a bit, and especially when you travel around Asia, for decades, face coverings have been something, whether it was a fashion statement or whatever they were doing, it was something they already were in the habit of doing. And even though I don't want people hearing me say, get used to this, we're going to be the face covering capital of the world. We can open up businesses if we can show, as human beings caring for one another, you know what, I'm going to wear a face mask until I get out to the restaurant, and then I'm only going to take it off when I'm sitting at the group with my table. Your businesses can open and have more people at the office. But we are a bit, how shall I say this? I think I said this to somebody the other day. We as West Texans are slow to believe it's a fight worth fighting. But when we finally believe it's a fight worth fighting, we fight like crazy. Yeah. And so this is just one of those occasions. Yeah. It seems like I can't control what I see. Well, I can. I can control what I see and listen to on social media. Like you said, I would just encourage people, be very careful about entering into conversations about social media, heeding your advice about whatever you hear coming out of the president's task force or the governor's task force, even what you hear us saying. Do your research, but do research on both sides of the issue. You know that as an educated man, that some people just want to research only what something says about what they want to believe, rather than reading both sides of the literature. And in today's extremes, it seems like in the middle somewhere is about where you're going to find the truth.
Right.
And right now, the only thing we can control is, in fact, when I was running up to the office to meet you, I got halfway here and I was like, oh, I forgot my mask. So I turned around, went back to the car, got my mask. And, there was a part of me that said, I'm just going to run in and get in the elevator. I'll be fine. But, I can't control that. And last thing, this is the last thing. I read the other day that they may even say this social distancing thing is a 3-foot thing and not a 6-foot thing. Have you seen that?
I have not.
Well, see, then that we can go back and look at that.
Yeah.
So,
I think it probably varies depending on what kind of an environment you're in and what you're doing at the time. Like, if you're yelling, I think I've seen some projections of breath. When you're yelling, it goes out more than 6 feet even. But probably sitting like we're sitting right now, you could probably be closer and it wouldn't be exposing one another. Yeah.
Any other things you wish I'd asked, or you had notes you wanted to say?
I got 2 comments that I'd like to make. One is from Michael Dragon, Dr. Michael Dragon, one of our urologists. I was on the phone with him this morning, and just fortuitously, he gave me some information, and I think this is a beautiful platform to share it. He wanted to remind everybody that we are getting into the middle of summer, late summer, and fall will be here soon. Please get influenza vaccinations this year. It is going to be a challenge in healthcare when people come in with fever and respiratory tract symptoms to know what we're dealing with COVID-19, influenza, RSV, and everything else that's out there. If we can decrease the amount of influenza, that will be to everyone's advantage. So please be a vaccinator and get a vaccine and take care of yourself.
That's a huge point. That's a huge point, really, from Dr. Dragon, to just say, go get the flu vaccine. We don't need to be mingling all this. Right.
It's going to be a challenge under any circumstances this fall. We're hoping to have some testing available that will do rapid testing for RSV, influenza, and COVID-19 all on one platform. So that will help us be discriminating more quickly. But like you've seen with every other testing we've done, don't hold your breath. I don't believe it until I see it. So let's be careful there. Second thing, I'd like to give a shout out to Dr. Bill Klingensmith. He's done a remarkable job in promoting convalescent plasma and getting people that have recovered from COVID-19 to donate plasma. We are doing a blood drive at the hospital on Thursday and Friday of next week. I've got some notes on here somewhere.
So like the 28th or 29th or something like that?
Yes. Yeah. And so there's...
it was in the paper this morning, so
good.
I know
Perfect.
It'll be out there.
Okay, so please, if you know someone or you are someone who's recovered from COVID-19, please, you have to be 28 days post-recovery. But if you're 4 weeks after recovery, please, if you get a chance, go and donate on those dates. Or you can go online to Vitaliant's website and donate, get online and register to donate. So those are my 2 last closing thoughts.
Well, and on the blood donation, are we just looking for a blood drive related to this convalescent care, or are we also still just in need of blood?
We are in short supply in blood products in general in the whole Permian Basin. So anybody who is willing and able to donate blood, we'd love to have them do that as well. But the convalescent plasma is an acute issue that's is relevant as well. But both.
Okay, you can say I don't want to comment on this, or you can. What are your concerns starting school?
Okay, I don't consider myself an expert, and I don't envy the position that Mr. Riddick finds himself in the school board and in the city in figuring this out. But I do have a little bit of information that I think can help formulate opinions. There seems to be a suggestion that elementary school kids are at low risk. Number one, they're at low risk even if they get the COVID-19 infection of being sick. I mean, very, very low risk. It's not like influenza. They don't get terribly sick. They may not even have symptoms. It seems that their level of transmission of the infection to others is lower as well. So if this information proves to be true, it seems that in the first K through 6 or so is probably a minimal risk, and we could be a little bit more liberal in what we're doing there. The older grades, I think you have to be a little bit more cautious, and it all goes back to what you were saying earlier. We can be widely exposing the 50s, 40s, 30-somethings, by and large, they're not going to get terribly sick. But when they get around people that are more vulnerable, it's a bigger problem. Yeah. So we have to worry about that. So that's a different population that have to be dealt with differently. But I think there's an opportunity. The kids have to get back together. They have to be socializing. We got to figure out a way to do that. But it's not going to be business as usual. And again, Mr. Riddick, my hat's off to you.
Good luck.
Job. Yeah.
Right. Well, I imagine that people I hope they've learned a lot. I hope we've been able to give some non-press conference feel here to our discussion and help people see that in the end, What I hope they see is us calmly saying to people, let's not panic, but let's take care of ourselves. Let's take care of each other. And about all we can do right now until we get to whatever is going to happen is put a mask on. We've all already said, I hate those things. I've even made the case, and we don't want to infringe upon people's civil liberties. But I also made the case in a recent Facebook Live that the greatest gift of freedom is what I can do for the benefit of others, not what I can do for myself. And right now, this is about the best way you can serve your neighbor is I'm going to make sure I'm taking care of my neighbor.
Keep them from getting the infection. That's right.
So, Dr. Wilson, thank you very much, and appreciate it.
Thank you.